Welcome back to The Explainer. So today we are diving into a really complex, honestly kind of notorious area of healthcare administration, the CMS rules for split or shared EM visits. I know, the source material can feel incredibly dense, almost like a giant puzzle, but we're going to unpack exactly what these facility setting rules mean together. Let's get right into it. Check out this fascinating and honestly slightly terrifying data point. A facility can actually bleed 15% of its rightful reimbursement simply because of coding errors on these shared visits. Yep, 15%. Misunderstanding these rules leaves a massive amount of compliant revenue just sitting on the table. So let's look at why that actually happens. Here is our roadmap for today. We'll be defining split shared visits, going over facility versus office rules, tackling the substantive portion rule, maximizing provider reimbursement, breaking down modifier FS, and documentation, and finally, looking at the top audit red flags. First up, defining split shared visits. All right, the foundation of our entire discussion really rests right here. What is it? Well, a split or shared visit is an E&M service provided jointly by a physician and a non-physician practitioner. You'll often hear them called an NPP or an APP, like a PA, an NP, or a clinical nurse specialist. But the criteria here are super specific. They absolutely must be working together in a facility setting and, crucially, this is a big one, they have to be in the exact same practice group. Oh, and by the way, you can report these for both new or established patients and for initial or subsequent visits. So, where do these visits actually happen in the real world? The CMS guidelines strictly limit them to specific eligible settings. We are talking about hospital inpatient and observation units, the ED, and nursing facilities. It even covers critical care units, provided those strict criteria are met, of course. Basically, if your provider is standing in one of these locations, you are firmly in split and shared territory. Section 2. Facility versus office rules. The source material draws a really hard line here, and you've got to pay attention to this. Split and shared visit rules apply exclusively to facility care. Literally, that's it. If the encounter shifts to a non-facility setting, like a private physician's office, well, these rules just completely disappear. Instead, office encounters are governed entirely by Incident 2 rules. Mixing these two up is a massive compliance trap, so keep them strictly separated in your mind. Moving on to number 3, the substantive portion rule. Okay, so who actually gets to bill for the visit? It all comes down to who performs what we call the substantive portion of the visit. And there are two ways to figure this out. The first is total time. This means one practitioner performs more than 50% of the combined time spent by both providers on that day. And remember that total time includes both distinct face-to-face and non-face-to-face time on the date of the encounter. The alternative method, that looks at the key component, the practitioner who actually performs and, importantly, substantiates the medical decision-making, the MDM, claims that substantive portion and reports the visit under their NPI. Which brings us to part 4, maximizing provider reimbursement. Establishing that substantive portion isn't just jumping through compliance hoops, guys. Here is the financial reality behind the rule. When the substantive portion, either through racking up more than 50% of the time or by driving the MDM, is proven to be performed by the physician, well, the visit is billed under their NPI. That yields 100% of the Medicare fee schedule. But if the NPP performs it, it's billed under their NPI at 85%. So if your documentation doesn't conclusively prove the physician did the bulk of the work, boom, 15% is literally just left on the table. Section 5. Modifier FS and documentation. Patient care in a facility is a team effort, right? So naturally, the documentation has to reflect that. To compliantly secure that full reimbursement, both providers must clearly document their distinct work and their face-to-face involvement. A physician can't simply swoop in at the end of the day and just casually sign off on a note without detailing their own independent contribution. It just doesn't work that way. The guidelines give us a super clear mandatory compliance checklist here. For the claims, you absolutely have to append modifier FS to the EM code to flag it as a split or shared visit. In the clinical note itself, both providers need to be clearly identified, face-to-face involvement has to be documented, and if you're using the time method, you need exact itemized time logs, no guessing. Finally, each provider needs to give substantive attestations of exactly what they did. Stay away from clone notes. They are a massive issue here. All right, let's move into our final section, number 6, top audit red flags. let's build some guardrails against those costly Medicare audits, shall we? Reviewing the CMS guidelines, there are 5 major red flags that will absolutely fail an audit. First, like we talked about, applying split and shared rules in a non-facility office setting. Total no-go. Second, missing explicit MDM or time documentation that actually proves who did the substantive portion. Third, omitting modifier FS on the claim. Fourth is double counting overlapping provider time. Look, if the MD and the PA are discussing the patient together for 10 minutes, that is 10 total minutes, not 20. You cannot double count concurrent time. And fifth, relying on those lazy, generic, I agree with the above co-signatures. The substantive provider has got to detail their specific work. I want to leave you with a pretty stark reminder from the source materials. Inaccurate billing isn't just an oops administrative error. It can actually lead to criminal and civil penalties. Knowing how to properly navigate these complex rules is absolutely crucial. The financial stakes are high, but the compliance risks, they are even higher. It really begs the question, is your facility's documentation truly audit-proof, or are you risking that 15% margin on a mere technicality? Think about it. Anyway, don't forget to like, share, and subscribe to Decode Healthcare with Herschel.